Most adults over 50 have made walking a regular part of their lives. They walk before breakfast, after dinner, through parks on weekends. That consistency genuinely matters, but it is not enough on its own. People who walk every single day are still developing knee pain that wasn't there 2 years ago. They are waking up with stiff hips they cannot explain. They are losing balance in small, quiet ways that worry them. The walking is not the problem. A set of specific, correctable mechanical errors is. I am Dr. Chris Health, and I've spent years working clinically with adults in their 50s, 60s, and 70s on movement mechanics, gait patterns, and joint preservation. What I saw consistently was not catastrophic injury from a single event. It was slow compounding tissue erosion in bodies being used in ways they were not designed for. These were not careless people. They were motivated, health-conscious individuals who simply lacked specific physiological knowledge. And in the body, that gap has a cost that compounds over time. What follows is not a general list of tips. It is a clear, mechanically grounded explanation of what actually happens inside your joints, muscles, and connective tissue when these errors occur. Some of what I describe will sound familiar, because it may describe exactly what you have been doing for years. That is not a failure. It is the starting point for a real correction. The first mistake happens within the opening 30 seconds of nearly every walk I have observed in patients over 50. They step outside and immediately move to full walking speed. No transition, no preparation. It feels efficient. It is, in practice, one of the most mechanically damaging ways to begin movement after a period of rest. To understand why, you need to understand how the cartilage inside your knee is nourished. Cartilage, the smooth, firm tissue that lines the ends of your thigh and shin bones inside the knee, has no direct blood supply. It receives its nutrients exclusively through synovial fluid, the lubricating fluid produced by the lining of the joint capsule. That fluid reaches the cartilage through a process called diffusion, which is driven by gentle, rhythmic compression and release of the joint during movement. When you are at rest, fluid distribution across the cartilage surface is uneven. Some areas compressed, some relatively dry. It takes gradual progressive movement to work that fluid back through the cartilage evenly. Think of it like a dry sponge. You have to work it gently before it can absorb uniformly. When you skip that preparation and jump straight to full stride, you are applying full load impact to cartilage that is not yet adequately lubricated. Each step at full pace before the cartilage is properly prepared generates a small amount of mechanical wear. After 50, the cells responsible for maintaining cartilage have significantly reduced repair capacity, meaning that wear does not fully reverse between sessions. The correction is straightforward. Walk at approximately half your normal pace for the first 5 minutes of every session. This is not a casual stroll. It is a deliberate joint preparation phase. After 5 minutes, increase to your preferred pace. If you pay close attention, you will actually feel a change, a subtle loosening, a reduction in the friction of motion. That moment is your cartilage reaching adequate lubrication for sustained load. The second mistake involves your head position while you walk, and the physics behind it are simple. The adult human head weighs between 10 and 12 pounds, roughly the weight of a bowling ball. When it sits directly over the spine, that weight travels straight down through the vertebrae in a clean, efficient line. But when the head drifts forward, which is what happens to most people who spend time looking at phones or screens, that load increases dramatically. At just 2 inches of forward displacement, the effective load on the cervical spine more than doubles. At 4 inches forward, which is common, that force can reach 60 pounds. That is the equivalent of carrying a 7-year-old child on your neck for the entire duration of your walk. The muscles of your upper back, the trapezius, the muscles between the shoulder blades, the deep neck extensors, and are forced into sustained contraction to stop the head from drifting further forward. Unlike muscles that are actively moving, muscles held in a fixed contraction without rest build up metabolic waste products and develop chronic low-grade tension. Over time, that tension radiates into the shoulders, the base of the skull, and eventually produces patterns of pain that are routinely misdiagnosed as rotator cuff problems or early arthritis. A patient I treated, a 62-year-old retired teacher, who had managed shoulder pain with anti-inflammatories for nearly 3 years before I examined her gait. Her head was consistently 4 to 5 inches in front of her shoulder line. We trained her to shift her gaze to a point roughly 15 feet ahead on the ground. A cue that mechanically prompts the neck and upper back to return toward neutral. Within 6 weeks, without changing her medication or activity level, she reported approximately a 40% reduction in pain. The correction I use clinically is simple. Imagine a thin cable attached to the very top of your skull, pulling you gently upward. Not rigid, not like a soldier at attention, but with a sense of length through the back of the neck. Your chin drops very slightly into a natural soft position. Your gaze falls 10 to 15 feet ahead. When your head returns to neutral alignment, your shoulders tend to follow without any deliberate effort because the tension that was holding them forward no longer has a reason to stay. The third mistake involves your walking shoes, and not the brand or price, but the condition of one specific internal layer that most people never think to check. The midsole, the layer of foam or gel between the outer rubber sole and the inner lining, is the primary shock-absorbing component of any walking shoe. Each foot strike on a hard surface sends a wave of force upward through your foot, ankle, knee, and hip. A healthy midsole compresses on impact and rebounds elastically, spreading that force across time and across a wider surface area. But foam undergoes what engineers call mechanical fatigue, the progressive breakdown of the molecular structure that gives it its spring. Most walking shoe midsoles reach functional failure between 300 and 500 miles of use. After that threshold, the foam compresses under load and stays compressed, like a mattress that has permanently lost its tension. The outside of the shoe may still look clean and intact, but the cushioning is functionally gone. After 50, this matters more than it did at 30 because of a second change occurring simultaneously in your own body. The fat pad on the bottom of your heel, a specialized tissue structure designed to absorb impact, thins measurably with age. In your 20s, this pad is roughly 18 millimeters thick and contributes meaningfully to every foot strike. By your mid-50s, it has lost approximately 30% of that thickness, and its internal structure has also degraded. Unlike the midsole of a shoe, this pad does not recover. Walking in a structurally dead shoe at 55 means both your primary and secondary shock absorption systems are compromised at the same time. The unabsorbed force goes directly into the plantar fascia, the Achilles tendon, the shin, and the joint surfaces of the knee. The practical solution: track your mileage. A moderate walking pace of around 2 to 3 miles per hour, walk for 30 minutes, 5 days a week, reaches 300 miles in about 20 weeks. Mark that date in your calendar. When you reach it, press your thumb firmly into the heel area of the midsole. A functional midsole gives noticeably under that pressure. A fatigued one feels like firm plastic. If it feels like plastic, replace the shoe, regardless of how it looks on the outside. Scheduled shoe replacement is not an indulgence. It is straightforward joint maintenance. The fourth mistake is made by some of the most disciplined walkers, the ones who consolidate their weekly activity into 2 long sessions on Saturday and Sunday. 7, 8, sometimes 10 miles across the weekend. The total distance looks similar to walking spread across the week. The physiological effect is not. When several days of low activity precede a long walk, the muscles that protect your joints are not at full readiness. The hip stabilizers, the muscles around the ankle, the deep stabilizers along the shin, so these lose their active contractile readiness after 48 to 72 hours of minimal use. When those muscles are not fully engaged, the load they would normally absorb is transferred directly to passive structures: cartilage, tendons, ligaments, and joint capsule. Then you rest for 5 more days and repeat the cycle. Every week, think of a bridge designed for constant moderate traffic. It handles that load well because the structural adaptations it makes are continuous and proportional. The same bridge loaded heavily only twice a week, with long intervals of no load between, develops fatigue failure at specific stress points, not from overuse, but from the repeated cycle of full rest and sudden high demand. Your body adapts to what you do consistently. It does not store fitness across 5 days of inactivity and deliver it on Saturday morning. 3 to 4 walks of 20 to 30 minutes, distributed across the week, produce better results across every relevant measure: joint integrity, cardiovascular adaptation, blood sugar regulation, and muscle maintenance, compared to 2 long weekend sessions. You do not need to walk every single day. You need to walk with enough frequency that your body stays in a continuous state of adaptation, rather than cycling between full rest and mechanical overload. The fifth mistake is one I rarely see discussed in standard exercise guidance, and when I raise it with patients, the reaction is almost always surprise. It involves what your arms are doing while you walk. Most adults over 50 walk with their arms either largely still at their sides or held in a vaguely bent position that is neither a functional swing nor a relaxed neutral. It feels normal because it has become habitual, but it is creating a measurable deficit in spinal health with every walk. Human gait is organized around a contralateral pattern. When the right leg advances, the left arm swings forward, and vice versa. This reciprocal arm swing does more than counterbalance rotational momentum. It drives what biomechanists call thoracic counterrotation, a gentle rhythmic twisting motion through the middle portion of the spine that occurs with each step. That rotation serves several critical functions simultaneously. It cycles the intervertebral discs, the shock-absorbing pads between each vertebra, through alternating pressure and release, which is how they receive nutrients and stay hydrated. It mobilizes the small paired joints at the back of each vertebra, keeping them moving through their designed range of motion rather than stiffening progressively. And it repetitively activates the multifidus, a deep layer of stabilizing muscle running the full length of the spine, which is the single most important structure for preventing the kind of low back pain that defines later life for so many people. When arm swing is absent or reduced, that entire cascade stops. The discs cycle less efficiently. The spinal joints sit in fixed positions throughout the walk. The multifidus, receiving no meaningful challenge, begins a slow atrophic process that characterizes a muscle that is no longer being used. Low back pain in later life is very frequently a multifidus atrophy problem long before it becomes a disc or joint disease. The correction requires no special effort. Flex your elbows to approximately 90 degrees. Let each arm swing forward and back in a relaxed pendulum-like arc. Not across the midline, not exaggerated, timed so the left arm comes forward as the right foot strikes the ground. Within about 30 seconds, you will feel a quiet loosening through your mid-back. That is the thoracic spine beginning to do what it was designed to do. The sixth mistake is statistically among the most consequential, and its consequences are not gradual. They arrive suddenly. A large proportion of adults over 50 walk while looking at their phones, reading messages, checking headlines, scrolling content. The primary risk this creates is not distraction, though that is real. The deeper issue is proprioception, your body's internal positional awareness system. Proprioception is the network of sensors embedded in your muscles, tendons, and joint capsules that continuously tells your brain where each part of your body is in space without you having to look. It is what lets you walk upstairs in a dark room without falling. After 50, proprioceptive sensitivity in the lower limbs declines measurably, particularly at the ankle, where the sensors in the joint capsule become less acute, and the response time between detecting an uneven surface and triggering the corrective muscle response becomes slightly longer. That delay is small in absolute terms. In terms of whether you catch a trip or go down, it is everything. In normal walking, peripheral vision is continuously scanning the terrain 3 to 15 feet ahead, giving the nervous system roughly half a second of preparatory time before each foot strike. That half second allows the postural muscles to pre-activate before an irregular surface is contacted. When your eyes are on a screen 6 inches from your face, that terrain reading is gone. A reduced proprioceptive system is now operating without its primary visual backup. Falls in people over 50 produce a specific injury profile, fractured wrists from reflexive catch attempts, and hip fractures from direct lateral impact. Hip fractures in adults over 65 carry a one-year mortality rate of 20 to 30%, not from the fracture itself, but from the cascade of complications that follow immobility in an older physiological system. Listen to your podcasts, take your calls, use earphones, keep your gaze moving across the path ahead, and save the screen for when you have stopped. That one change eliminates a fall risk factor that is entirely preventable. The seventh mistake is the one that most resembles discipline, which is exactly why it is the hardest to correct. It is the refusal to rest, the insistence on walking every day, regardless of physical state, treating soreness and fatigue as weakness to overcome, rather than as signals to be read. After 50, tissue repair following exercise operates on a longer timeline than it did at 30. The satellite cells responsible for repairing the microscopic muscle fiber damage that occurs during any sustained exercise are less numerous and less rapidly recruited in older muscle. The inflammatory process that initiates repair is also slower to resolve, meaning metabolic waste products remain elevated in the tissue for longer after a session. Walking on tissue that has not completed its repair cycle does not produce a training effect. It layers additional microstructural damage over incompletely healed tissue. Over time, that is not fitness building. It is accumulation of damage. There is a post-walk recovery sequence I have used clinically for years. It takes approximately 5 minutes, requires no equipment, and produces measurably better next-day joint comfort than rest alone. Sit on a firm chair near the front edge, so your spine is unsupported. Take 3 slow breaths, belly expanding first, then chest, and exhale fully each time, allowing your shoulders to drop completely on the last exhale. This activates the parasympathetic nervous system, shifting the body from the active exercise state toward the recovery state in which tissue repair is prioritized. Rotate both ankles, clockwise for 10 full rotations, then counterclockwise for 10. Any slight clicking is normal. The movement is redistributing synovial fluid through the ankle joint and restoring the hydration gradient in the cartilage. Place both hands on your right thigh, just above the knee. Slowly extend the leg until nearly straight, then return, 8 times, slowly. That gentle quadriceps contraction cycles venous blood through the lower limb, clearing the post-exercise metabolic byproducts that accumulate during walking. Repeat on the left. Stand with feet hip-width apart and rise slowly onto both forefeet simultaneously. Hold the peak position for 2 seconds, then lower with deliberate control. 10 repetitions. This loads the calf, the Achilles tendon, and the arch of the foot through their full range, promoting the collagen turnover that keeps those structures resilient. Finally, stand flat-footed and shake each leg loosely from the hip for 10 seconds. A simple neuromuscular reset that releases residual tension in the lower limb muscles. The entire sequence takes under 5 minutes. It does not look impressive. But what it is doing, redistributing articular fluid, clearing metabolic waste, maintaining neuromuscular readiness in the stabilizing muscles of the ankle and knee, is precisely what the post-walk physiology is asking for, and almost nobody provides it. Before I close, I want to describe one patient whose case I return to often because it illustrates, in a single story, everything covered here. He was 68 years old and had walked 4 miles every morning for nearly 20 years. He was proud of that record, and rightly so. About 2 years before I saw him, he had developed what he described as a deep, persistent fatigue in his legs that sleep did not resolve. He had also fallen twice, once on a garden path, once stepping off a curb. Neither fall caused lasting injury, but the second one had shaken him in a way he had not fully admitted to his family. His general practitioner had evaluated him thoroughly: cardiac function, thyroid, full blood panel, all results within normal range. He was told to continue walking. When I reviewed his gait and habits in detail, what I found was essentially all 7 of the errors I have described, working together and without interruption for years. His shoes were almost 2 years old, and the midsoles were structurally exhausted. He never warmed up. He walked with his phone in his right hand, screen facing up, reading while he moved. His arms were static throughout. He walked all 7 days of the week, including days when his legs were noticeably sore. He had developed forward head posture so deeply habitual that he was genuinely unaware of it until I showed him a recording of his own gait. We made changes one at a time over 8 weeks. New footwear immediately, then the warm-up protocol, arm swing correction, head position retraining, a reduction to 5 walks per week, and the post-walk recovery sequence on every walking day. At the end of those 8 weeks, he said something I have written down and kept. He said, "I didn't feel like I was walking differently. I felt like I was walking again. Not better." Again, as though the accumulated habits had disconnected him from the actual experience of movement, and the corrections had restored that connection. That distinction matters beyond mechanics. When you understand what your body is actually doing, when you are working with its design rather than against it, movement stops feeling like maintenance and starts feeling like something more fundamental. Your body at 50, 60, 70 is not a degraded version of what it was. It is a physiologically distinct system that requires more precise inputs, better information, and a different quality of attention. Walking is not a fallback activity chosen when nothing harder is available. It is one of the most biomechanically complex, neurologically integrated movements the human body performs, and doing it well is entirely within your reach. To bring everything together, begin every walk with 5 minutes at half pace to allow your joint cartilage to reach adequate lubrication before full mechanical load. Restore neutral head position so your cervical spine is not sustaining a load it was never designed to carry alone. Track your mileage and replace your walking shoes when the midsole reaches structural fatigue before the outside of the shoe gives you any warning. Distribute your walking across 3 to 4 sessions per week so your stabilizing muscles remain in continuous adaptation rather than cycling between dormancy and shock. Activate a reciprocal arm swing with elbows bent to 90 degrees to drive spinal rotation, disc hydration, and deep stabilizer activation. Keep your visual field on the terrain ahead, rather than a phone screen, especially on any surface that is not perfectly flat. And add the 5-minute post-walk recovery sequence after every session, because what happens in those 5 minutes significantly shapes what happens to your joints over the next several years. One practical action before your next medical appointment. Ask your physician specifically whether your walking mechanics and footwear condition may be contributing to any musculoskeletal symptoms you have been describing. Most general practitioners will not raise this question on their own, but most will engage with it seriously when a patient does. That single question can shift the conversation from managing symptoms toward addressing mechanical cause, which is where lasting solutions are actually found. Drop a comment below. How long has walking been part of your regular routine? 1 year, 10 years longer? I read them, and the answers genuinely inform what I cover next. Everything presented here is general health and wellness information provided for educational purposes only. It does not constitute personalized medical advice and is not a substitute for diagnosis or treatment by a licensed healthcare professional. Individual anatomy, medical history, and health status vary significantly, and what is described here may not apply to your specific situation. Before modifying your exercise routine, particularly if you are experiencing joint pain, have a diagnosed musculoskeletal or cardiovascular condition, or take medications that may affect balance, circulation, or muscle function, consult your physician or a qualified healthcare provider who has full knowledge of your medical history.